That's where the peak airway pressure is. That's where the total volume is. These are loops that you see in control mode of ventilation. Assisted mode, you will see a little twist at the bottom. If it is spontaneous, you will see inspiration starting from the negative and expiration coming in the positive. Okay, so even looking at the flow volume loop, you can say whether the patient is in the controlled mode of ventilation, assisted mode, or spontaneous. Just like in the flow and pressure scalar. Okay, now, what is it here? That is PEEP. If you apply PEEP, the whole scalar moves to your right. That's what you need to know. Okay. Sorry? Under two slides? Yeah. Okay. Now, the flow times, the pressure volume scalar will also tell us about the work done. The area of the curve, the area within the loop tells us the work. Okay, I'll show you how that, if someone's breathing like that, they are doing more work. So the work of breathing increases. So you look at the loop. If the loop is looking bigger, has become more obese, that means your patient is working harder. Okay. Look at that. That is the normal pressure volume loop. If the pressure volume loop goes to sleep, that means the compliance is poor. Okay. Pressure volume loop falling down, going to sleep, the compliance is poor. Okay. Let's see how the pressure volume loop will tell you about resistance. That's the normal. Look at the next one. Here, the whole inspiratory part gets pushed to the right, whereas the expiratory almost remains the same. Okay, that is typical picture of an increased resistance. And if you see this happening, that's a normal. Okay, beaking. The tip of the curve just going out like a beak, it tells you that, oh, you are over distending the lung. Okay, but fine. And the last, if you see a loop which is not touching the baseline, it tells you there is air leak. Okay, so these are just quick examples of what graphics can tell you. It's not possible to cover the whole graphics in a 20-minute talk, because graphics are actually advanced mechanical ventilation topics. Okay. Thank you.
Thank you very much, Dr. Abraham, for the very clear understanding of the graphics. Before you disperse for the lunch, there is an important announcement. Please stay for a while.
We'll start hands-on from 45 minutes each station. So we'll start with the registration number from 1 to 30 to station number 1, 31 to 60, station number 2, the same way 61 to 90, station number 3, 91 to 120, station number 4, and 121 to 150, station number 5. So subsequently we will go on. Once we complete the one course, we can go to the second station. Sub-station 1 can move forward to station number 2, and that's where we can continue. Station number 5 can come again to station number 1. So this will continue, and we'll see you at 2:30. Thanks.
Fine. So we'll just ask 25 there, 25 here, 25 here, 25 here. Fine. I mean 25. It's all over. Fine. 30. Inspirator cycle में
Since we are not connected,
once you say you want to activate it, you just activate.
or if
important nowadays because it is less invasive and it is continuous. These two things are very important. So what we are doing, we are using a technology called PICO, and there is a very small catheter. This is the catheter, which is only required to conduct the entire process. So it's a 20 centimeter long catheter with 5 centimeters of thickness. And can you hear me what I'm saying? Yeah. And this catheter is generally inserted into one of the arterial line, preferred as a femoral arterial line. But you can have a radial catheter and distal arterial catheter also. Now, since this is a minimal invasive technique, if you are referring to the previous technique like Swan Gans,
So that is
where you have to insert it.
cardiac output है
Yeah.
और ये फिर साथ
Transpulmonary, we inject a cold solution into the right atrium through the central venous axis, but into the arterial line. So it completes the complete transpulmonary phase. And now when we talk about the continuous cardiac output, the machine also has the capacity of measuring thermodilution, normal cardiac output with the help of Swan Gans. So you have a dual combo module because some people are still preferring to have a pulmonary capillary wedge pressure and right cardiac output pressure. So we are having both these things together.
Sometimes you give with the ambush bag. The same thing which you do with the ambush bag is done by the ventilator. But ventilator, as I told you earlier, it is not a. If you are not a good clinician, the ventilator really can't do much to the patient. It helps you to buy time so that as you address the condition which resulted in respiratory failure, you can take care of it. Okay? So these are the basic thing about ventilation. So when you have to start a ventilation, I think that when they discuss setting of a ventilator, they discuss, but I will discuss with you the basic concept.
What do you think is, what are the important things in this you feel? Patient is having tracheostomy. Patient is not in bed. He is having support of parenteral nutrition. He also has RT, plus he also has support of parenteral successful. What else strikes you?
This continuous suction system.
There is closed suction system. With tracheostomy, the suction catheter which has been put in there, it is a closed, what is called as closed suction catheter system. Very true. So that the chances also when you are using closed suction system, de-recruitment of lung doesn't happen. Or it is less likely to happen when you are using it as a closed suction system. What else? Then the nurses, how many nurses are there? So is that important? Nursing ratio. So it is important.
You can see the change in temperature can be seen on the monitor with the help of a curve, and this is a real time. At the same time, you can see the temperature become 36.8 because what happens? Your right atrium temperature is nothing but a blood temperature of 4 degrees in that. The total temperature of 37 will start. This is not exactly happening in right atrium; it is actually happening into the femoral artery because you are measuring into femoral artery. If you correlate the same principle with a right heart principle of Swan Gans, then the
Newer ventilators, they don't write down. They will only write down IE. But roughly you know that this much you give, that what will be the flow. Okay? So you give a flow to the patient, and when you fix a 500 ml, when the 500 ml is reached, inspiratory volume. So this is a volume control. Time triggered, like I fix up 12 breaths per minute. So every 5 seconds, inspiratory valve is opening.
Injury and you are ventilating the patient. Under what category he will come? Okay, we'll go from here. Huh? What am I ventilating? Why pumping? Brain is involved, but is breathing.
Central.
But does every patient has loss of central drive after head injury? So you are ventilating for what? Decrease the ICT. But does that work for prolonged period? How do you decrease ICG? By ventilation? Hyperventilating, by CO2 washout. And that effect lasts only for few hours. So it is basically to avoid secondary insults to brain. Brain is already injured. And if there is hypoxia on top of it, if there is hypercapnia on top of it, the brain injury or
The volume now patient gets will depend on the resistance of the airway and the compliance of lung chest. So this is the only difference. Both can be time triggered and patient triggered. One is getting a flow Actually air is coming, this is the number you given. So when I say flow, pressure will differ, whatever pressure. If there is a leakage, pressure will be more. But machine will ensure the patient gets that flow. And when your cycling mechanism reach, and the inspiration will end expiration.
TCO, machine is going to tell you how much is continuous cardiac output of the patient at the moment. Average values stored and TCO calculated. The moment I do that, you can see all the values appear on the screen in the same moment. So, what is the patient's cardiac output? 6.3 liters. It was showing 5.8 there, but as it is a continuous cardiac output, depending upon the stroke volume variation, it is bit to bit changing. So machine takes an average of 4 to 5 contractions, it's 5.7, and this is the biggest advantage what we have. In terms of our previous technology of Swan. Now let us look at the parameters what are available from this. We are having extravascular lung water, which is 515 ml. This is nothing but a combination of blood of all the 4 chambers. Global end-diastolic volume. Global end-diastolic volume is nothing but a combination of blood in all the 4 chambers of the heart. You come to know how much it is that. Then you come to know intrathoracic.
What happened in posterior approach, the chances of picking the artery is less, because you can see the vein is here and then the artery is there. So you are always going to hit the vein first. Whatever technique you use, you should know the landmarks. Okay? Towards the same side of nipple, then that is known as extravascular. If you are trying to put the posterior approach, then what you have to do is that the clavicular head of sternocleidomastoid and the external jugular vein, you see that, and this is where the crossing is there. In between these two, you can puncture. When you are puncturing,
the patient's heart rate, arterial pressure, systolic V,
this is very sure in your landmark.
and all the
When you are
parameters
puncturing, first is towards the suprasternal circle.
and you come to know patient SPR, systolic activity is 156 lines, and left
Right?
cardiac work, left ventricular stroke work, and
This is your posterior triangle approach. Okay?
we approximately around
You have to
An SpO2 of 92%. So our goal is not 100% SaO2. Okay, 90% is adequate. So you reduce FiO2 as much as possible. Whether ABG should be done. So as soon as you put the patient on ventilator, do first ABG, and then do another ABG after 1 to 2 hours, so that your settings you should find how the patient is reacting to it, whether that is adequate or whether there is unnecessary washout of CO2 or whether there is accumulation or acidosis. You have to check that and fine tune your settings for that.
CPAP, or you call it pressure support, plus P is the same. But if you're not giving any pressure support, it becomes a simple thing. You understood?
Patient is breathing well, nurses control. Since patient is breathing well, nurses control. All pressure, spontaneously patient is breathing. Then what will be the advantage of putting patient on SIM with pressure support?
If patient is breathing
Spontaneously or nurses control.
spontaneously, patient is a different word. Don't use these words spontaneous. Assist is, of course, patient is spontaneously
There will be
triggering.
backup
See,
ventilation.
the difference between assist control is, the only thing is that patient can initiate. Rest, ventilator takes it. You know, in assist control, the only thing is the patient triggers. Rest, machine says now it's my job. In a pressure support, machine triggers, gives a pressure, but the cycling is also patient takes control. This is it.
go just below the clavicle, opposite shoulder. Okay? I tell you, the place will be proper in identifying the landmark. That is most important. Don't try to be in hurry and never put a line in hurry and overconfident. Okay? You have to just go below the clerical, okay, and then go divert towards the opposite shoulder of keep a little bit to substance.
Keep the things near normal, near to normal, but not up to the normal. So thermodynamics, what was being used in Swanganj, he was using central vein, right atrium, right ventricle and then pulmonary artery. So central vein में हम डालते थे और जो right ventricle से eject होता था and that temperature dropped flow and time was put on.
Is dropping. Anytime anybody goes on ventilator, BP will drop. So you may have to give some amount of volume. Okay? Peak for pressure gradient will be normal in this. Lungs are normal. Peak pressure is not high, pause pressure not high. Central alarms. So in this, what are the alarms?
Machine itself.
Yes, time trigger, time-based signal.
So whatever the volume is fixed, the machine will deliver that volume. With the pressure is variable and